Welcome to Mid One Pager. My name is Benjamin, and today I'm going to be talking about abortion, or what we call miscarriage. So, if you're someone who enjoys high yield medical videos, or you find visual learning a big part of how you understand things better, concepts better, then I would urge you to please subscribe to the channel, because we make videos like this every day, every week, and we have different topics being discussed that are actually very, very important both for your examinations, and we do the conditions that we commonly you will find on the word. So let's get started. My name is Benjamin, and abortion is going to be a term that is faced with a frown most of the times, because when most people hear the word abortion, they think it is something that is deliberate, or it's the termination of a pregnancy. But abortion in medical language can be spontaneous. It can be what you would by courtesy call a miscarriage. So abortion is pregnancy loss, but this occurs before viability. This is before the age of viability, and different countries have different ages of viability. You find that in my country, Uganda, the age of viability is around 26 weeks. So if someone loses a pregnancy before 26 weeks, then we say it's abortion. In the UK, it may be a bit lower, or in other countries. So we have main groups of abortion, and we have the spontaneous abortion. This is the one that occurs on its own, what most people will call the miscarriage. And then we have the induced, which is the termination or the intentional termination of pregnancy. We have other kind of terminologies that are used to further go ahead and be specific. We have the unsafe abortions, those that are done outside of the clinical setting or in the hands of untrained people. And then we have the septic abortion, where we have an abortion that goes ahead and gets complicated with an infection. So when you classify it by intention, you have the spontaneous, the induced, the unsafe, as well as the septic. Then we have the different causes that are going to cause miscarriages, and these are very important to understand. Now we shall make a video about recurrent miscarriages, and we'll see what brings them about, what causes them. But for the early miscarriages, guess if this is going to be maybe a first time or a recurrent, it does not matter. Most of them are going to be due to chromosomal abnormalities, and this is what most people don't actually understand, that when the body finds that the baby or the fetus that is being formed has chromosomal abnormalities, sometimes it goes ahead and allows it to pass out. That is an miscarriage, and this is going to occur very, very early, at around within the almost first 4 weeks of the pregnancy. Then maternal age can be a cause of miscarriage. Previous miscarriage increases the risk of you getting another miscarriage, because most of the times whatever caused the other one to go out may actually be still available. And we shall look at recurrent miscarriages, as I said, and you will appreciate that a lot of these things, sometimes you have chromosomal abnormalities that are persisting both on the man and the woman's side, that will continue to cause these miscarriages. Diseases like diabetes are very important, and that is why it's very important to optimize the sugars before someone actually tries to conceive. Then thyroid disease, you can have things like obesity, you can have smoking, alcohol, drugs, and severe systemic illnesses. Now in Uganda, you find that many women go ahead and get malaria during pregnancy and actually end up aborting or getting a miscarriage. It is something that is common, but basically any severe systemic illness can lead to loss of a fetus. So we have the late miscarriages, or these are going to occur in the later trimesters. Most of them are going to be due to anatomical issues, as well as thrombophilias, or issues to do with coagulation, because as we shall see, as the pregnancy grows, the placenta has to develop in order to sustain that fetus. And sometimes as the placenta undergoes things like maturation, it's getting older and older, the placenta's supply to the fetus can be compromised, and then you end up having a miscarriage. So we have cervical insufficiency. That is when the cervix is not closing very well. It can be due to various factors. It may be due to previous surgery on that cervix. It could be a congenital kind of anomaly or something like that. That could actually cause miscarriage, especially later in the second trimester, because as the fetus grows bigger, you expect it to stay in the womb. If it doesn't, it slips out miscarriage. Then you have uterine anomalies. Sometimes you have like a septic uterus where the uterus did not actually separate very well. Maybe you have a fibroid inside there that is going to occupy space and it's going to push the fetus, and that is going to cause a miscarriage. Things like infection, antiphospholipid syndrome, or thrombophilias, as we have said, you have that thrombosis of the vessels, and that can cause pregnancy loss. Then trauma as well as placental problems. So when you look at the pathophysiology, what actually happens is going to be depending on the specific factor. But for things like aneuploid, this is the most common chromosomal abnormality that occurs. You have a failed development of that fetus, and beta HCG goes down as well as progesterone. And once you have beta HCG low as well as progesterone, then you can't maintain that pregnancy because the decidual is going to break down, and the decidual is that interface that supplies the fetus or the embryo with nutrient until the placenta takes over. So it's going to die early, and then you have bleeding, contractions will ensue, and then expulsion of the conceptus. Then we have retained products that can cause the bleeding, because for the uterus to contract, products have to be away. There has to be no placenta attached. So when bleeding occurs, sometimes infections can ascend through the cervix, and then you have that. Then sometimes we have unsafe instrumentation, use of instruments that are known to sterile, or if someone used something that is not sterile, that can cause uterine injury as well as sepsis. Sometimes you have cervical insufficiency, and the key characteristic in cervical insufficiency is that these women come in with painless bleeding. Someone is there, they notice blood coming out, they don't have any pain, they don't have any cramps, and then later they realize that there is products of conception. That is going to be cervical insufficiency, and painless dilatation is going to be a very, very common finding in this area or in this particular course. So when you look at the clinical features, most of the time a woman who comes with blood, we are going to think about ectopic pregnancy, because that is the top differential, it's the most deadly differential. But down the list, one of the things that cannot mean is that this woman is aborting or she's having a miscarriage. So vaginal bleeding is going to be a very common finding, if not always there in all cases. Then crampy lower abdominal pain is going to be there, back pain, passage of clots or tissue. Sometimes they be stuck within the cervical os, and you can only see them on examination. Reduced pregnancy symptoms, you have regression of these symptoms of pregnancy, as well as dizziness or syncope if there is severe bleeding. So we have the red flags. When you see things like shock, heavy bleeding, you have fever, a foul smell, severe abdominal pain, there is a peritonism, or they have this tenderness when you try to touch the abdomen, there is syncope, shoulder tip pain is actually a sign of that peritoneal irritation of the blood. So sometimes you have blood trickling through until the diaphragm, and you know the diaphragm is supplied by the same nerve that supplies actually your shoulder. So when that blood irritates the diaphragm, you're going to feel that shoulder tip pain. It's also seen in things like splenic rupture, and it can be a sign of an emergency. So we have a persistent positive pregnancy test and ongoing pain, bleeding after treatment. So when we want to look at the ultrasound clues, what do you see that tells you what type of abortion you have? Because we have some types of abortion, and these are very highly examinable. So we have the threatened abortion. This one, the pregnancy can continue, but it may go ahead and be lost. So it's a threatened abortion. We have an incomplete abortion. We have a complete abortion. So incomplete, you have nothing left in the uterus. Everything has been evacuated. A complete, and you have an empty uterus. With incomplete, there are some products that are remaining. It could be the placenta, it could be the fetal tissue, anything like that. Then we have a missed abortion. Now with a missed abortion is when you had a pregnancy before, you don't notice the blood, you don't see anything, but you find that there is no heartbeat or the sac is now empty. That's going to be a missed abortion. But it's important to know that whenever you have no intrauterine pregnancy and you have a positive HCG test, this is an ectopic pregnancy. And I can't stress ectopic pregnancy enough, because this is what is going to kill many people if you do not get to know it early enough. So always rule out ectopic pregnancy in any pregnant woman who is bleeding. Then abnormal intrauterine tissue and high SCG can signal a molar pregnancy. Now, I did a video about ectopic pregnancy. I did a video about molar pregnancy. If you have not watched those, or if you want to revise, you can go ahead and check out those videos in the OBGYN playlist. So we have differentials. Again, top differential is going to be ectopic pregnancy. That is going to be always top. Molar pregnancy comes second. Implantation bleeding. We have subchorionic hematoma. You can have a cervicitis. Cervical cancer can cause that vaginal bleeding. PID, UTI, appendicitis, ovarian cyst, accident, like torsion and things like that can all cause that pain. So investigations, you want to do the URAM or SURAM pregnancy tests, you want to do a CBC, you want to cross match, you want to do the BTHCG, transvaginal ultrasound, CRP and cultures, as well as urinalysis and electrolytes. These are going to be very, very important. Basically, rule out anything life-threatening, as well as make sure you are resuscitating that woman. If she needs blood, give her blood, things like that. So when you look at the threatened abortion, what really happens in a threatened abortion? You have bleeding for the vagina, but when you do the ultrasound, you find that the cervical os is closed and the fetus still has a heartbeat, so we have a viable fetus. And most of the time what you do, you want to reassure the mother, you want to give them analgesia, you want to make sure they are not moving around. Ultrasound confirmation is very, very, very key. And you want to avoid unnecessary intervention. Don't go ahead and try to do this and that when you actually don't need to. You know, when people have threatening conditions, sometimes they are over treated, and that can be deleterious in some conditions. Then you want to consider progesterone if bleeding, and this is a very controversial thing, but I'll leave it right here because sometimes progesterone are shown to have no effect on prolonging the pregnancy, and studies have contradicted each other in the past. So it's something that you have to consider if you see fit. So especially if there has been a previous miscarriage. So then we have the inevitable abortion, and it's very important that whenever you're learning these types of abortion, you know what happens in the os, what you see, and what happens with the products of conception. So a little trick I use is that anything that has I in it, the os is going to be open. So when you have inevitable abortion, the os, the cervical os, is going to be open. When you have incomplete abortion, still the cervical os is going to be open. So inevitable abortion, the os is open. Once the os opens, that pregnancy cannot continue. You never close that os, and once you don't close that os, everything is going to come out. So you have an open os, you have bleeding and no complete expulsion. That is going to be an inevitable abortion. You're going to go ahead and assess the bleeding, stabilize the mother, give analgesia, and then you choose whether to continue medically or surgically. And when you talk medically, that's you're going to give misoprostol, and then it will induce contractions that will push out this product of conception. That's especially if a pregnancy is less than 13 weeks. Then the surgical is when you do the dilatation and curettage. Sometimes you can do the mandal vacuum aspiration or the suction aspiration, anything of the sort. Then we have the incomplete. Now, the incomplete, you have some products pass, but some are staying. So what you do, complete it. You're going to make sure the mother is stable, and once they are stable, you go ahead and you can use drugs if the pregnancy was early, if it's a bit later, because during the early pregnancy, the placenta has not undergone that second invasion, so it's a bit easy to remove medically. But after the second invasion of the placenta, the trophoblast invasion, then you need to really scrape it off. Otherwise, the bleeding won't stop. So you do the surgical, the curettage, or the suction evacuation. And then there may be heavy bleeding. You need to do evacuation. Whenever you see the bleeding, you want to evacuate. Once you evacuate and remove those products of conception, then the bleeding might stop. There is a risk of infection, especially because you're doing instrumentation, as well as, of course, the cervix being open and the other predisposing factors to the infection. Make sure so you give antibiotics after the evacuation. You correct the anemia and correct the shock if it's there. Then you have the complete abortion. This occurs when you have all the products expelled. So you don't need to do evacuation. You confirm the uterus is empty when you do ultrasound. You follow up with a pregnancy test and see if things go down, because sometimes you can have a molar pregnancy and that may persist with HCG, and you know that molar pregnancy has a risk of turning into the gestational trophoblastic malignancy. Then you want to give contraception counseling. So we have the septic abortion. This is very important to know, and most of the thing that is going to be characterized in septic abortion is you have fever, you have uterine pain, and a foul discharge, plus or minus shock. So this is going to be a septic shock. If you find the mother is having pain, when you touch their belly, they feel a lot of pain, and then they have a foul discharge, think septic abortion, and it's an emergency. You want to follow ABCDs, IV access and fluids. You want to do the CBC, the culture, the lactate, giving and electrolytes, as well as coagulation. And then you want to give the broad spectrum IV antibiotics, evacuate the retained products, treat septic shock, as well as you have to consider that they could have a perforation, they could have an abscess, especially if there is peritonealism or if they're having peritoneal symptoms. So we have post-abortion care, and this is another important aspect that you have to actually understand, because once you manage this mother, or once someone has aborted, you have to always give them post-abortion care, and it's sometimes tested in examinations. So you want to confirm completion always. Ensure that they have completed aborting. If they have not, then you help them complete. You want to treat bleeding or anemia. You want to treat infection or prevent infection, that is antibiotics. Manage their pain. If they are rhesus negative, always give the anti-D. This cannot be stressed enough. They're going to lose their next pregnancy if you don't give them the anti-D. Then make sure you give them contraception before discharge, or give them the knowledge and the choice to start contraception before the discharge. You don't want them to get pregnant again within a short time, because if you have done curettage on that uterus, it's not yet stable. They're going to get a pregnancy, they're going to lose it again. So you don't want them to undergo that stress again. Please make sure you encourage them to use contraception. Then STI screening or treatment if there is a risk. Emotional support, and this cannot be stressed enough. This is someone who's going back to their family, they have lost a child, they have had these expectations of a child. Emotional support is very important, both for the mother as well as the husband. Then clear return precautions. If you don't tell the mother that if you see this and this happening, if the bleeding is persistent, please do come back. If you feel feverish, or if there's a false smelling discharge, come back. They won't come back, they're going to become septic, and you would be to blame because you withheld that information. So the exome traps are commonly going to come. Early pregnancy bleeding, the first differential will always be ectopic until you prove it otherwise. Threatened abortion, you have a closed os. Inevitable, you have an open os. Then look at the products of conception. Incomplete, they're still there. Complete, they are done. Missed, you have a dead pregnancy, it was retained there. The body will go ahead and try to resorb that tissue. Then whenever you have fever, tenderness, and foul discharge, then think septic abortion. Painless second trimester pregnancy loss is going to most of the time be a cervical insufficiency. If you have a persistent HCG after abortion, then heavily consider that there could be a molar pregnancy. So heavy bleeding plus shock, make sure you resuscitate the mother first. So we have come to the end of this video, and I hope it makes a lot of sense and highlights a lot of important key points when it comes to abortion. Let's meet in the next video. My name is Benjamin. Don't forget to subscribe to the channel, leave a like, drop a comment.